Assalamu alaikum. Good evening. Thank you for the kind invitation. It's an honor to be here among friends and colleagues. And again, congratulations to the organizing committee on a very successful and ever-growing meeting. I've decided to change the topic of my talk. Actually, I'm going to talk about something totally different. So today, we've been given the task to talk about interventional updates, focus on 2025. And what we're going to do today is we're going to sort of go over this in topics. And we're going to touch a little bit on every topic of those, more of a superficial approach, getting the knowledge out rather than a deep dive. We'll talk about aortic valve stenosis and interventions there. The AI, or the AR actually, is going to be a separate presentation tomorrow. We'll talk about mitral valve, tricuspid valve, and left atrial appendage occlusion devices. So this is a great review article that was published in 2025, and you can see it here. It talks about severe aortic stenosis, and we're going to go over some of the things that were described here, and we'll talk about the studies that actually will affect our practice and moving forward. So we'll talk about TAVR in young patients. We'll talk a little bit about asymptomatic aortic stenosis, intervention on moderate aortic stenosis patients, especially with heart failure, intervention on patients with previous SAVR with a failed biprosthesis, small aortic annuli, low flow, low gradient bicuspid valves, and the AI again, or the AR, is going to be discussed tomorrow. We're not going to spend too much time on the list of studies, but we're going to just touch on the low flow, low gradient. And as you all know, this is just a reminder that you can have this phenomena with a low ejection fraction, where the recommendation is to do the beauty stress challenge to define whether it's pseudostenosis or real stenosis, and the paradoxical low flow normal EF, where you actually are recommended to do a calcium score and look at stroke volume index of 35 or less. The DEDICATE trial was one of the trials that actually reported outcomes in low-risk patients, and as you can see here, the data is strongly in favor of TAVI over SAVR in low-risk population, and this is the 12-month data. It is very, very encouraging, especially with the multitude of TAVR's trials that we've seen, and we'll go over some of those as we go forward. That was a one-year follow-up on the DEDICATE trial. The three-year follow-up of the NOTION 2 trial came out as well, and it shows non-inferiority for surgery versus TAVR. So TAVR now is cementing its place. And as we look at this, as you all seen this, the hemodynamic and effective orifice area are very favorable, and the benefit is sustained at 3 years. New York Heart Classification improvement is discussed, and the overall score for quality of life is also improved. This study actually included the bicuspid as well as tricuspid valve, and we'll talk about the bicuspid a little later in the talk. But as you can see here, although numerically surgery fares a little better, but there was no statistically significant difference in between the two arms. So it appears that TAVRs also save in bicuspid aortic valves. The 5-year outcomes for the Evolute valve, and as you can see here, again, at 5 years, the initial results hold valid, and we see that the durability and the sustainability of the results maintained at 5 years for the Evolute valve. So this was a big deal. This is the 7-year follow-up for the Partner 3, and this was presented at TCT by Michael Mack, and Marty Leon was actually moderating the session. And as you can read, you read the paper, it's very worth reading, and you'll be introduced to a concept of data missingness, which means that after 7 years, you're missing some data. And one of the things that they did to get around that is to do the vital status sweeps, where they looked at, called the patient's families, looked at obituaries, and looked at the Medicare database to look at patients who are still alive versus the ones that are not. And as you can see here, at 7 years, there is no statistically significant difference between TAVR and SAVR in all these different outcomes. All cause mortality, all cause stroke, and the primary endpoint. And biprosthetic valve failure was not different between the two valves. So the question is, are TAVRs as durable as SAVRs? The answer here, for 7 years, it is probably the case. So the Notion trial was also a low-risk trial, and this we have 10-year follow-up. And the 10-year follow-up here is quite interesting because, as you can see, all-cause mortality was no different, and all-cause mortality, stroke or MI, was no different. When you look at severe structural valve degeneration, you will see that it's actually in favor of the TAVI versus the SAVR. And severe prosthetic valve degeneration, and you can see the definition on the bottom of the slide, which includes structural as well as other factors, actually strongly in favor of the TAVI in terms of the bioprosthesis valve degeneration. So, and you can see that the difference is very, very early. And some people argue that you actually achieved better valve area and better hemodynamics with the TAVR in favor as compared to SAVR patients. So, 10 years out, TAVRs are doing just as well, if not better, than surgical valves. Meta-analysis of randomized trials, and as you can see here, in terms of mortality, if I can have this is not working. So if you can look here, the first to the top left is mortality and is stratified by low risk versus intermediate risk and high risk patients. There's no difference between TAVI and SAVRs. On the bottom, mortality again stratified by type of valve. There's no difference there. On the right side of the screen, death or disabling stroke, again by severity of the disease and the low risk patients, as well as the type of the valve. And you can see there's no difference between these outcomes. If you go down now to pacemaker implantation, there's significantly worse outcomes with self-expanding TAVRs. And this is balanced further on the right slide with the valve gradients, which are better in self-expanding TAVRs as compared to balloon expandable TAVRs. So there's a price to pay for each one of these devices, but overall, we agree that the outcomes are comparable between TAVIs and SAVRs at 10 years and the meta-analysis. So things are actually very, very promising for TAVR severe aortic stenosis. Let's shift gears a little bit and talk about asymptomatic severe aortic stenosis. The previous session had a long presentation on asymptomatic patients. Early TAVR was presented, and as you can see here, there's significant improvement in the outcomes with TAVR versus clinical surveillance. This was mostly driven by unplanned hospitalizations for cardiovascular causes. And as you can see here, about 70% of the patients crossed over from surveillance to intervention within the first 18 months. So you can watch the patients, but you risk increased incidence of hospitalization for heart failure. And the important part here is that there was no penalty to pay. There was no increased complications in the patients who underwent early TAVIs as compared to the surveillance. So something to consider. What about small annuli? The SMART trial was presented, I think it was 2024, and as you all know, there was no difference for disabling stroke, rehospitalization, or heart failure. But as you can see here, the bioprosthetic valve dysfunction was significantly higher in the balloon expandable valve. So for small annuli, balloon expandable valves have higher gradients and marks higher incidence of bioprosthetic valve dysfunction. As you can see here, the mean gradients are higher for balloon expandable. The effective orifice area is higher in self-expanding, and the hemodynamic, structural, and bioprosthetic dysfunction are significantly higher in balloon expandable. So if you have a small valve, small annulus, consider your choice of device. Now, some people argue that there were a lot of critics for the study, but the data is presented as you see it here, and you make your own decision. So meta-analysis randomized controlled trial propensity score matched for balloon expandable versus self-expanding. It's a hot topic. And as you can see here, again, for effective orifice area, favor self-expanding. For transvalvular mean pressure gradients, favor self-expanding. Over to the right, I do apologize for no laser. Transvalvular peak and gradient, again, favor self-expanding, and the paravalvular leak was no different. So you can understand here that if you have a small annuli, you probably want to consider your options here. I'm going to skip over this. The MyValve catheter, the MyValve transcatheter heart valve, we do not have this available to us in the United States, but the landmark trial. Let's see. Yes, thank you. So the landmark trial compared my valve to current use Sapien and Evolute. And as you can see here, the performance of the my valve was similar to the contemporary use, again, for effective orifice area and gradients, and this benefit was maintained about 1 year out. So this again shows the effectiveness, efficacy, and durability of the my valve as a platform. Do you all have my valve here as one of the options? Panelists, yes?
Yeah.
Okay. And as you can see here, all-cause mortality, rehospitalization, clinical efficacy, and all stroke are the same. So my valve seems to be a good functioning platform. Bicuspid aortic valve stenosis. The number of patients undergoing TAVI for bicuspid is increasing, and here is a sort of a plan for what constitutes high-risk anatomy for TAVI versus amenable anatomy for TAVI. We're not going to go through all this. You can read them as you can see them here. But again, the calcification and the eccentricity are a challenge for patients with bicuspid aortic valves. Transcatheter valve versus TAVI versus surgical for bicuspid valve. This is a paper by Vinay Badwar. And this was a retrospective analysis of a large database. This was not propensity matched, it was not randomized, and it inherently does have a lot of selection bias. And as you can see here, the data is strongly in favor of surgery in bicuspid aortic valves, both in terms of stroke as well as mortality for surgical versus TAVI. So this gives you a little bit of a hint of maybe we should think a little deeper about bicuspid valves. If you look back at this paper back in 2019, and this was a large database, but it was propensity matched. And as you can see here, the main differences are patients who had surgery had more blood transfusions, and patients who had TAVIs had more complete heart block and pacemakers. But there's no difference in mortality, there's no difference in bioprosthetic valve degeneration. Again, a lot of us do this, especially in high-risk patients, and this data is sort of reassuring, but definitely worth a deeper thought for bicuspid aortic valves. Okay, balloon versus self-expanding for bicuspid aortic valve stenosis. There really is no difference. Whatever platform you're comfortable with, if you decide to go forward with a TAVI on a bicuspid aortic valve, you will see that what the data supports both platforms. Some people argue supraannular leaflet position is favorable. Some people argue better and accurate landing zone with the balloon expandable is better. Whatever you're comfortable with is probably the way to go. So let's talk about moderate aortic stenosis. Should we be doing TAVIs on moderate aortic stenosis, especially in patients with heart failure? This is the TAVR Unload. And after 12-month follow-up, there was no difference between the surveillance group and the TAVI group in patients with moderate aortic stenosis who have congestive heart failure. And you can see the primary endpoints was the hierarchical occurrence of all these endpoints. Okay. So, there's been a lot of data about Van Vliet valve. And we'll talk a little bit about this in not great detail, but this is a good paper by Santiago Garcia looking at TAVI in SAVRs, in failed SAVRs. And as you can see, the incidence of use of TAVI in SAVRs is greatly increasing. And there are a lot of modes of failure, whether it's stenosis or regurgitation, and it's important to take into consideration the type of valve that has been used, the surgical valve, whether it's fracturable or not, the positioning of your TAVI within the previously implanted bioprosthesis, and the space that is available after your valve is implanted between the VTC and the VTA. And these are some things that to keep in mind. When you are faced with a small surgical bioprosthesis, there is the option for fracturing the surgical valve. There are a couple of surgical valves that are not fracturable. The trifecta and the Hancock. Everything else is fracturable, and you should consider this as one of the options in case you're worried about patient prosthesis mismatch. Lifelong management of TAVI patients. TAV and TAV is becoming more prevalent as the patients have been implanted. And this is a great paper by Vinay Bapat looking at the concept of where to land your second TAVI and TAV. And these are multiple iterations of, are we actually doing a sapien and evolute, or evolute and sapien, or the same valve? The concept here comes for leaflet overhang, the concept here of neo-skirt placement, out plane, and of course the coronary wrist plane. And what you want to see is that your coronary wrist plane is higher than the neo-skirt. The neo-skirt is where the two set of leaflets are continuous and they form a long skirt that may actually be higher than your coronary wrist plane, and then you risk coronary occlusion or decreased access to coronary in the future. It helps that you have a wider coronary sinus, and you have to look at your valve to coronary distance and valve to aorta distance. All these are factors to consider when you are doing TAV and TAV. The new designs are there, and I'm not going to go through all of these. These are two specific designs, the Jenna valve and the J valve for aortic regurgitation. We're going to talk about that tomorrow, and new embolic protection devices. This is an interesting paper actually that came out recently. This was about using a minimalistic approach versus standard of care. This comes out of Germany. Look at their standard of care. Standard of care is local anesthesia, unconscious sedation. This is standard of care. And when they went minimalistic, they went without the conscious sedation, and they did everything with with local anesthesia. Patient is awake. Interestingly, the outcomes were very, very similar. There was no increased complications when the patients are awake if you talk to them and allow them to be involved without moderate sedation. There was increased stress and anxiety when the patients were awake, but that did not affect the outcomes. So something to consider about how minimalistic the interventional group is becoming with this. Cerebroembolic protection devices, the BHF Protect, the routine use of the protection device did not cause any decrease in incidence of strokes, and this was a large trial, 3,800 patients in each arm. And as you can see here, this is the primary outcome: stroke, secondary outcomes, strokes, severe stroke, death. And as you can see here, there is no difference in the outcomes between the control group and the embolic protection group. This is irrespective of what kind of valve you used, whether you pre-dilated the valve or post-dilated the valve, or you saw a lot of aortic valve calcification. That made no difference in the outcomes and with the use of embolic protection devices. So again, there's no way to detect which patients are going to suffer a stroke, but this data is strongly supportive that the routine use of this did not decrease the events in this population. This is an interesting study that was presented by David Cohen at TCT, and this is looking at the prevalence of valve disease in patients who have no history of any valve problems or cardiac problems, age 65 to 85. And exclusion criteria: complex heart disease, congenital heart disease was excluded. They looked for 3,000 patients. The interesting part of the study is that this was actually an outreach. They reached out to pharmacies, they reached out to primary care physicians, and enlisted some of the patients that potentially could be enrolled. They had them do an e-consent, and they went to their homes and did the echoes. Quite an involved effort. And as you can see here, that if you're over 80, then you have a 14% chance of having more than moderate valvular heart disease. And the most two prevalent formats of this was aortic stenosis and tricuspid regurgitation. And if you sort of overlay this on the population of the United States, you can sort of imagine how many patients are actually. 5 minutes. All right, let's go zip through this. Frailty predicts geriatrics. So we'll go. We're skipping this. We're skipping this, unfortunately. All right. TEER, mitral clip, reshaped heart failure trial, looked at patients with functional mitral regurgitation, looking at patients with moderate or severe mitral regurgitation who have functional MR, and this was compared to controls. And as you can see here, that the device did much, much better than the control group. This is the Matterhorn comparing mitral clip to surgery, and as you can see here, there was the outcomes were comparable between surgery and mitral clip. Major adverse events, This is free from event, which was significantly higher in the interventional group, mostly because of peri-surgical events seen in the surgical group. The ENCIRCLE trial looked at the SAPIEN implantable TMVR, and as you can see here, it met its endpoint by performing better than the performance goal set for the trial, with significant reduction of mitral regurgitation and improvement in your heart classification. The Tendyne, again, was presented in calcification, and it definitely met its primary endpoint with the performance for that platform. And as you know, this is a transapical approach. Platelet leaflet modification techniques, the Batman. Now we're doing the Batman collaboration, which is a registry of these patients. This procedure was described in 2019, and it's gaining a lot of popularity, and now we're doing the registry. Transcatheter tricuspid valve. This is a great paper, actually, looking at the review, the TTVR challenges, the pacemaker leads, conduction abnormalities, thrombosis, and RV dysfunction are all challenges when you're looking at tricuspid valves. The Triluminate was a tricuspid tear, and as you can see here, reduction in the severity of tricuspid regurgitation and primary endpoint in favor of the tear group as compared to the control group, with statistically significant p-values in all these primary and secondary endpoints. So if you look at the tricuspid tear, it is definitely beneficial. This was 800 patients from the experience, real time, real world. And as you can see, the position, whether it's distal or close to the center, you can see that more than 80% received more than one clip. And again, significant reduction in TR severity and improvement in quality of life. This is the EVOQUE tricuspid valve transcatheter replacement. And as you can see here, there is significant improvement in quality of life in New York heart classification and reduction in tricuspid regurgitation with the TRISCEND 2 trial with the EVOQUE implantation, with, again, very favorable outcomes for the control group versus the valve group.
1 minute.
1 minute. Going. All right. The EVOQUE, we're done. So, left atrial appendage occlusion device, the ANDES trial, looked at DOACs versus DAPT. And as you can see here, there was increased bleeding with DAPT as compared to DOAC, but also increased thrombosis with DOAC as compared to DAPT. So as you can see here, this is again in favor of the use of DOAC in favor as compared to DAPT in patients with left atrial appendage occlusion. This is interesting because you don't usually have increased thrombosis and increased bleeding. If you bleed more, then you reduce your thrombosis. This was again a fluke, I believe, and is still in the analysis phase. Both are statistically significant. So this is something for food for thought as you look at your anticoagulation, antiplatelet therapy for your left atrial appendage closure patients. Thank you.